Well, thank you, and I'm very pleased to, pardon me, I'm very pleased to be here. I want to thank the IOM and the National Research Council for inviting me, especially Tracy Lustig and Christy Park for putting together such a fantastic conference, and to Alan, Jed, and Frank Lynn for having the vision to put all of this together. I'm going to briefly introduce myself, and I'll start by saying that I am not an expert on hearing loss. What I am is a primary care physician and a geriatrician. So I help to oversee a very large family medicine department in the country. It's the University of Minnesota. We have 4 different primary care clinics in underserved areas and train about 150 residents in family medicine. And so we're one of the players in training primary care workforce. I've also done a lot of work with the American Geriatrics Society and serve as a representative for that organization as well. It's an organization of about 6,000 older adult healthcare workers, and I can give you my perspective as a geriatrician from that standpoint. The main point I want to make, and that point has been made over and over again the last 2 days, is that the different ways of attacking the problem of hearing loss, and there have been 2 main ways, and that is one from a healthcare standpoint, and that would be from medicine and public health. And then the other one really is from a tech or environmental standpoint. Those 2 different fundamental ways of approaching this problem really need to come together, and that's the main point I want to make. I'm going to get back to that at the end of my brief comments. But I'm a doctor, and so I'm going to speak a little bit about my own personal challenges and observations from approaching this problem from a medical standpoint. Let me describe to you some of the hurdles I see, at least from a medical standpoint, of trying to approach this problem in a primary care setting. I'll tell you a little bit about the setting of my own personal practice. It's in South Minneapolis. It's a very underserved community. It's a very busy clinic. We're training residents, we're training mental health workers and pharmacists at the same clinic. We're a family medicine department in an era of poor compensation for primary care, so we're struggling to remain financially viable. The average age of my patients in the clinic is about 85, and they're all pretty darn frail. And on average, I usually, through the course of a half-day in clinic, I will use 3 different interpreters. And I unfortunately don't speak any of those languages. So it's a pretty challenging setting to deliver care. Now, given that setting, I see at least 6 hurdles, and I'm going to briefly describe all 6 to the approach of appropriate approach to care for hearing loss. The first is a structural problem. And this is something that Dr. Burkhart touched on, and that is that we've got a system in medicine where everything is predicated on the visit. Everything is predicated on my seeing the patient. So nothing can go on when I'm not seeing the patient. Everything has to happen when I'm seeing the patient in terms of compensation and so forth. And that is just a bad way to set up medical care, because of course most of the stuff that happens to patients is when they're not seeing me. So that's a structural impediment. The second is the era of evidence-based medicine, and I think this is an unintended consequence, is that in an era of evidence-based medicine, we have gone at sometimes, I think, to extremes, where we demand the evidence to show that something works. Now, we know in medicine that many of the things we do in medicine, there's no evidence. There's no evidence if I put my stethoscope on Charlotte's chest that is an evidence-based procedure for a doctor to do, unless she's complaining of chest pain. Okay, so, but we do it, right? And patients expect it. So I think we sometimes get handcuffed by the whole idea of evidence-based medicine, and when we're starting to tie funding into evidence and so forth, that can really hamper our abilities to forward an important endeavor. The next one is a problem I call the tyranny of the acute, and I don't call it. That was a term that was coined by Tom Bodenheimer and Kevin Grumbach at UCSF, and they talk about in a busy practice, when you're trying to get evidence-based, proper prevention and chronic disease management things done, the tyranny of the acute. The patient comes in, they have an acute need, and you spend all of your time dealing with the acute problem, and there's no time. Of course, everything has to happen to the visit. None of this can happen outside of the visit. So it's the tyranny of the acute. Now, I think there are two more tyrannies that we have to deal with when we're seeing patients, and I'm going to describe those. The next one is the tyranny of chronic illness. When I started in family medicine and I was taking care of patients with diabetes, a diabetes checkup and often involved looking at a few numbers that the patient had written down, and then I adjust the dosage of their NPH insulin and their regular insulin, and then I was finished. Go on to the next patient. Well, now if I see somebody with diabetes, there's about 15 things that have to happen in diabetes, and those are good things. And these aren't bad things. I mean, I'm providing better care than I've ever provided in my life for my patients with diabetes. But that's a lot to do. And so that when I'm seeing somebody who has diabetes and they have an acute need and I address the acute need and I'm trying to deal with the diabetes, oh yeah, maybe I should check them for hearing loss too. You know, I can't remember to do all those things. And then the last one is the tyranny of, the last tyranny, there are three tyrannies. The last tyranny is the tyranny of prevention and health maintenance. And there's a lot of stuff to do in prevention and health maintenance. Lloyd Michener at Duke in 2003 and his colleagues published an article in the American Journal of Public Health, good journal, that looked at all of the different, preventive activities that somebody had to do and standardized it to a standard family medicine practice. It turned out that 7.4 hours a day, if you were doing everything that you were supposed to be doing with your patients in a standard family medicine practice, would be spent on prevention and health maintenance. So obviously that just can't, you know, that is an awful burden. The annual wellness visit, I was talking with some colleagues at lunch about the annual wellness visit. It's great that hearing's on there, but let me tell you, follow me around during an annual wellness visit. There's a lot to get done in one of those AWVs, and it's not easy to accomplish. So I'm not speaking out against it. I'm just saying that it's a challenge when all those other tyrannies are going on to accomplish an annual wellness visit. And the last one, the last burden is that I think hearing loss belongs in this curious set of problems that are often neglected in medical education and training. So if somebody in residency mentions heart failure, you've got this warm fuzzy in your face. You know, heart failure, I know about the heart, I know about this, and then if somebody mentions incontinence or falls or self-neglect, any of the geriatric syndromes, or if they mention hearing loss or driving problems, you sort of wring your hands a little bit, futz around and stare at your toes and well, let's talk about their heart failure. So I think that, you know, that is another burden that we need to approach in education and training. So to come up with some solutions and my three priority areas, my first comment is that doctors and a medical approach alone, given all of those tyrannies that I talked about, is not going to solve the problem. Okay?
If you agree, you should indicate.
Yeah. I mean, not everybody is Tom Powers out there. So Tom gave a very nice presentation yesterday, but he's the exception, okay? And not everybody's as clued in as he is. And so I think we just can't clone Tom and expect expect medicine to take care of this. So we must change the equation. So I'm going to suggest three ways of changing the equation. These are big ticket items that I don't think you're going to have any problem with. The first is we need to advocate for better health policy to remove the barriers that need to be removed to facilitate better care for hearing loss. And those are structural, I think those are structural and financial barriers. The structural barriers are those about the way care is provided and organized around medical visits. We need to get away from that, and certainly the ACA and patient-centered medical homes and ACOs and so forth are moving in that direction, but we've got a long way to go as far as that happens. And then, of course, we need to remove the financial barriers, primarily the financial burden of hearing-assisted technologies and hearing aids. That's number one. All right, number two is is awareness. We need to continue to pound the pavement and increase awareness about this problem. We need to educate the populace and the workforce. I'm proud to say that American Geriatrics Society takes this problem very seriously, and through its foundation, the Health and Aging Foundation, you can find it in healthinaging.org. That's healthinaging.org, which is a website that's designed as a resource for patients and caregivers. There's an Aging and Health A to Z web page in there where you can draw up hearing loss and find lots of useful information as a patient. There's a site on what to ask. What do you ask your care provider when you go in to see them? And there's stuff in there about hearing loss when you're in what to ask. And then there's a whole set of pages for caregivers at the AGS Health and Aging Foundation website. And there's sections for the caregivers on hearing loss and communication techniques. So that's number 2, raising awareness. And number 3 is that we need action and we need research. We need better research. We need to research on how to partner medicine, health, public health, and technology to come together to really create better environments and better ways of looking at this problem. We need more research, and we need to fund people like Dr. Lin and Dr. Albert and other folks who are looking into this problem from a variety of different perspectives. We've delineated, I think, very well the research gaps. And finally, we need research into implementation. And so the kind of things that, Meg Walhagen is doing and lots of other folks in this room, and really how can we implement these things to provide some help for our older adults. Thank you very much for your attention on this. And I'll turn it over to Charlotte.